Hello, I'd like to welcome all of you to our program today, Liver Health for Veterans, Understanding the Risks and Complications of Liver Disease. My name is Morgan Harrington, and I am the National Manager of Programs here at American Liver Foundation. We are honored to partner with the U.S. Department of Veteran Affairs and the Veterans Health Administration to develop liver-specific educational content tailored to veterans and their caregivers. We are deeply grateful for their dedication and commitment to supporting the American Liver Foundation's efforts to build meaningful, impactful content and for their support of today's program. We look forward to continuing this important work together to improve liver health outcomes for the veteran community. ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs, resources for patients, caregivers, and providers. You can find more information at liverfoundation.org. Our new resource is the American Liver Foundation Patient Registry, the first ever patient registry for all liver diseases. Our goal is to help researchers better understand liver disease and how these diseases and current treatment options impact patient lives. The registry is open to individuals 18 and older in the United States with any type of liver disease at any stage, including transplant recipients. Participation is easy and includes a user-friendly online survey that will take about 15 to 30 minutes of your time. Please feel free to use this QR code or link to learn more to participate in the registry. We also want to highlight American Liver Foundation's Veteran Information Center, a dedicated resource for veterans and their families. Here you will find helpful information on MASLD, cirrhosis, HCC, and more, along with tools and support tailored for the veteran community. We'd also like to invite you all to join our Liver Health for Veterans Facebook group, a supportive space to connect, ask questions, and share experiences with others who understand the journey. Join today to be part of a growing community of support. I'd like to go ahead and start welcoming some of our wonderful presenters today. To get us started, we have Dr. Sophia Jacob. She is an associate professor of medicine at Yale University in the section of digestive diseases and the associate chief of hepatology at the VA Connecticut Healthcare System. I'm going to turn it over to Dr. Jacob to finish introductions as today's moderator.
Thank you, Morgan, and thank you, the ALF team, for getting us together, and thank you all for joining us. We have a great program and a great group for you today. Dr. Baffy is going to get us started. He is Chief of Gastroenterology at VA Boston. He's Associate Professor of Medicine at Harvard, and he's involved in several multi-center studies on advanced liver disease and liver cancer. Following is going to be Dr. Hang. She's Assistant Professor of Medicine at Emory University. She's Director of Hepatology at Atlanta VA. She leads the Multidisciplinary Liver Tumor Board, and she's passionate about health equity and medical education. Dr. Rabiee will finish our discussion. She's Director of Hepatology and Chief of Transplant Services at Washington, D.C. VA Medical Center. She's Associate Professor of Medicine at Georgetown University. Her main research interest is liver cancer and portal hypertension, and she will close the program with her present discussion of liver cancer. We also have a great panel to help with your questions. Karine Rosenberg, she has a doctorate in pharmacology, and she's truly a force in the VA. She was amazing, helping us cure many patients with hepatitis C, and she is an important part of our field advisory board on steatotic liver disease and viral hepatitis. Last but definitely not least, Dr. Teddy. I'm very biased because she's my chief. So Dr. Teddy is our chief in the section of digestive diseases at VA Connecticut. She's professor of medicine at Yale. She started the tumor board for the whole Northeast region. And as I said, we are very happy to have such a great group. So Dr. Baffy, please get us started with steatotic liver disease.
Thank you very much. I will try to do it. I hope you can see can you hear me and hopefully see the slides?
We can hear you. The slides are loading. Yes, good to go.
Wonderful, thank you. So my role is to talk a few minutes about metabolic dysfunction-associated steatotic liver disease. What a tongue twister that has become. It is actually a couple of years ago that this new nomenclature was born to replace fatty liver disease, as we have been using it for many different entities. We kind of kept the original setup, except that metabolic dysfunction-associated steatotic liver disease, or MASLD, as I will call it from now on, is a new group that replaced the non-alcoholic fatty liver disease category. It actually covers pretty much the same number of people with this disease in most effects, but the most important thing is that we define it based on its association with metabolic dysfunction, and I will just show in a moment how we define it. And of course, at the same time, we kept all other sources of fatty or steatotic liver disease, trying to get rid of a stigma, as many patient advocate groups define this, and then we decided to go away from calling it fatty. Although every single time we have to explain what steatosis or steatotic liver is. And then we have this in-between category between alcohol-associated and metabolic dysfunction-associated liver disease, where both injuries are present in the liver. So this is the definition of MASLD. You have to have steatosis, which is found based on imaging or liver biopsy or even biochemistry methods. And then you have to have at least one cardiometabolic risk factor, no more than one. And then that makes this disease quite inclusive, because if you have too little good cholesterol or too much triglycerides, or you have overweight or obesity, you have high blood pressure and so on, one of these 5 major categories that actually define metabolic syndrome is enough to call it MASLD. The MAT-ALD, which is this in-between category, in addition to these 2 definitions, has to have moderate alcohol use. Not too much, not too little, but something in between, as you see, for men and then for women. And then that will actually define this new category, which is an entirely new definition, which we call MAT-ALD. MASLD is a very prevalent disease. As you see here, there are many areas in the world where you have it up to 1/3 of the population, and unfortunately that includes North America. And we know that about 70% of people who have diabetes have this condition. Up to 90% of those who have obesity have this condition. But unfortunately, we know that up to 1/3 almost of people who do not have either diabetes or obesity might still have some underlying metabolic dysfunction and might have the disease. There are many different liver-related outcomes in MASLD. As I mentioned, about 1/3 of the population has it, and 1 out of 6 or 5 people will eventually develop this condition that we call metabolic dysfunction-associated steatohepatitis with variable degrees of liver scarring or fibrosis. And of these, every 5 years, up to 10% will progress into cirrhosis. This is the same cirrhosis, unfortunately, that we see with hepatitis C, that we see with alcohol, that we see with many different conditions. It's basically chronic advanced liver disease, which will actually get into decompensation. You might have ascites, you might have variceal bleeding, you might have encephalopathy. All these events will accumulate, and eventually the patient either dies or we might be able to save them with transplantation. One thing that is also part of the spectrum is liver cancer, primary liver cancer, or HCC. which is primarily developing in people who have cirrhosis, but most unfortunately in MASLD, the old rule that you would not probably have liver cancer unless you already have cirrhosis is not true anymore, because about up to 50% of people, it's a large number of people, will develop HCC even if they do not have established cirrhosis. That's a major problem. Now, who would develop what, and then who would respond to what type of therapy? It's very important. That's just a brief slide. I could talk about this for an hour, but we actually have to define subgroups within this very large group of people with MASLD. And then some of them have a very strong genetic component. Some of them are basically having mostly behavioral issues, very, very significant excess calorie, and so on. There are others who have adipose tissue abnormality. Primarily, the adipose tissue is not able to handle enough lipid, and then that lipid will be dumped into liver. We might see it in people living with HIV. We might see it in certain other genetic disorders. But obviously, when you see these clusters or subgroups of people with different phenotypes, we really have to approach their management in a different way. The most important thing, however, is that people will develop fibrosis. When they do, they have an increasing risk. With more fibrosis, they have more likelihood that they will have a higher liver-related death rate. But the key issue is here that even all-cause mortality will triple, quadruple as the fibrosis is going on. So that's a very important message. Even as you see here on the right side, when it's MetALD, when you have two different components of disease etiologies, then you have more and more fibrosis, which obviously, again, metabolic dysfunction and alcohol together will cause more damage, and that will cause much worse outcomes at the end. The other lesson is that just because you have liver disease, it doesn't mean that that will be a major fatal outcome at the end of life. On the left, you see general population where cardiovascular disease and non-liver cancer are the leading causes of all-cause mortality. On the right, you see people who have MASLD. And again, you still see that most of people with MASLD will die of cardiovascular causes and non-liver cancer. Of course, you see that compared to here, liver disease becomes quite a significant fraction of mortality. But the lesson is that most people with MASLD at every stage of the disease will have a very major likelihood that they will have cardiovascular disease and they will have non-liver cancer. We have a recommendation how to do primary risk assessment in MASLD. If you have steatosis, if you have repeated enzyme elevations, and you have all those metabolic dysfunctions or any of those, you probably have MASLD by the definition. We put this issue in the middle, so all these things you have to consider when it comes to management of the disease: the hypertension, the lipids, the diabetes, the alcohol, and so on. We just wanted to emphasize that that's true for everyone across the board, whoever has MASLD. But of course, we have to find out who has advanced fibrosis or at least significant fibrosis, because those are the ones who really are prone to a problem and increased mortality. And then with using the FIB-4, which is a very simple biochemical panel or score, that includes all these two enzymes, the platelet count and age, and then you can tell who is the one who can remain in primary care, who is the one who definitely needs to shift into liver clinic and evaluation, and who are the ones who are in the indeterminate range, which is quite significant, about 30–40% of the MASLD population. And then you can decide who would need a step 2 assessment to verify fibrosis with more sophisticated methods such as FibroScan or liver elastography, which is a very easy 5-minute test. It's non-invasive, and it has a range, and then we can define who is in the no or the very advanced fibrosis category and who is in between. And then these things will more or less correlate with the histological definition of fibrosis. Now, when it comes to the the management, a lot of people are involved in this. And then you see that there are so many components of the comprehensive lifestyle modification, which remains the cornerstone of disease, even as I will just say 2 words or 3 words about pharmacotherapy. But weight management remains a very important cornerstone, which we try to achieve with lifestyle modification. It makes a lot of sense, because if you have weight loss over 10%, even fibrosis might regress in up to 50% of people. And then that might happen even without medication. If somebody is able to do and achieve that significant amount of weight loss, as you see, unfortunately, that really is a small portion of the population. We can do this weight loss with lifestyle, with pharmacotherapy. We can do it even with bariatric or metabolic surgical interventions and even endoscopy. And the more you are able to do with weight loss, the better you are, not just in terms of liver-related problems, but in cardiovascular and other morbidity. Unfortunately, achieving is difficult, but whatever you do, if you stop it, then unfortunately overweight and obesity comes back with a vengeance, and then that makes it a very difficult situation. The good news is that we have 2 drugs now that are approved for the treatment. One is resmetirom, which is a weight neutral, so to speak, medication. It works in different ways. It works on the liver with the lipid metabolism. And the other one is semaglutide, which is well known. This is indeed a weight loss medication, and then it has been used for years in obesity, and it also works for diabetes. Now both are approved, and then both will be, even semaglutide is available now for MASLD as a single indication, regardless of obesity or diabetes, although in the VA we still are working out the details of eligibility. This is just briefly show that resmetirom worked both on the left side on improving the steatohepatitis, the inflammatory component. On the right, you see that it improves the fibrosis component, which is wonderful in many patients. Actually, I don't show it here. When the combined effect was seen, that both the inflammatory and the fibrotic component was improved. Still, we know that unfortunately, not everybody responds to this medication. The same is true for semaglutide. Here you see, compared to placebo, you have a significant improvement in both the inflammatory and then also in the fibrotic component. So briefly, MASLD is both a liver disease and, so to speak, we could say that it's a cardiometabolic risk factor in itself, which means all stages of MASLD are associated with increased all-cause mortality. So we have to pay attention to both the liver and then beyond the liver. We have a 2-step strategy that many different healthcare systems are using in the world. It's reasonably cost efficient, and then that's what we have to use for primary and secondary risk assessment. Comprehensive lifestyle modification remains the cornerstone, even beyond these wonderful new medications that we have, resmetirom and semaglutide. And then we have a very robust pipeline, hopefully, to have even better results that I just showed. Thank you. That's it. I hope I was not too long.
Thank you, Dr. Baffy. We'll switch to Dr. Hang. While the slides are loading, Dr. Hang is going to talk to us about cirrhosis. So we hope we can help many patients not to get to this stage, but please take it away, Dr. Hang.
Okay. So I know Dr. Baffy touched a little bit about it, but for today, I'll be talking about cirrhosis of the liver. So what is cirrhosis? Cirrhosis is when the liver gets attacked and it gets damaged by something. And so these liver cells start to die, and then scar tissue or fibrosis starts to form. In the early stages of this scar tissue or fibrosis, it is reversible, meaning that scar tissue can go away and the liver can heal itself. However, over the years, as the entire liver gets scarred, it ends up shrinking, and it gets hard to the point where it might not be reversible anymore, and that's considered cirrhosis. So we've kind of discussed briefly some common causes of cirrhosis. So significant alcohol intake, and that includes both all beer, liquor, and or wine. Viruses like hepatitis B and C, and then the buildup of fatty deposits from MASLD, like we had just discussed. Now, symptoms of cirrhosis. So you might not actually have any symptoms at first. We look at 2 different stages of cirrhosis: compensated cirrhosis or decompensated cirrhosis. So when you have compensated cirrhosis, this might be on the earlier stages where you still have enough healthy liver cells to keep up with your body's need. However, if nothing is done about the cause of your initial cirrhosis, these cells end up getting overwhelmed, and then your liver might stop functioning. And then you might switch to what we call decompensated cirrhosis. Symptoms at this point might include low energy or fatigue, poor appetite, weight loss, losing muscle mass, yellowing of the eyes and skin or jaundice, and then more serious problems from increased pressures in the veins from that scarring that you have or portal hypertension, which we'll go into. So first and foremost, bleeding varices, esophageal varices or internal bleeding. So this is when you have abnormally large blood vessels or varices inside your esophagus or your food pipe and other areas within your gastrointestinal tract, like the stomach or even sometimes in the colon or rectum. So pressure can start to build up in these areas. And when there's so much pressure that builds up, they can burst open and cause life-threatening bleeding. So symptoms can be if you're vomiting blood, you're starting to have black tarry stools. If that's the case, you do need to seek urgent medical attention to see what's going on. So we fortunately do have ways to prevent this from happening. So we have specific blood pressure medications that are within a group called non-selective beta blockers. The most common ones you'll see are carvedilol. Other ones are propranolol and nadolol. So if you are at risk for these varices and you're eligible to it, your provider might start you on these medications to prevent these significant bleeds. If for some reason you can't be on these medications or you developed bleeding, then we have an upper endoscopy procedure, which we would take a camera and go down the mouth of food pipe, and then we can put some tiny rubber bands around these varices to stop the bleeding or prevent any bleeding. Next decompensation you can have is called ascites, or fluid developing in the belly. So what happens when you have liver scarring like this, fluid starts to leak out of the liver and into the belly, and then you can get abdominal swelling. Treatments for this do include being on a low salt diet, so no more than 2 grams a day. Sometimes we can start you on water pills. It might be one water pill or a combination of things like spironolactone or furosemide. And then if these water pills can't control the fluid or the amount of fluid is just too much or you can't take the water pills, we can perform a procedure called a paracentesis. This is where a special needle is inserted into the belly and then the fluid can be drained. And these are outpatient procedures and they can be repeated as needed. If you have ascites and then you start having a new fever or belly pain, you should get medical attention just because sometimes infection of this fluid can be life-threatening. Hepatic encephalopathy or confusion. So this is when the liver can't get rid of toxins anymore, such as ammonia. So these are things that normally the liver should be able to do, but when you have cirrhosis, your liver really can't handle that anymore. So ammonia goes to the brain and then it can cause some confusion. It can also just alter your sleep-wake cycle. You might find yourself not being able to concentrate very well anymore, and you have some poor memory issues. In severe cases, this can actually cause a coma. Treatment for these, we can start a medication called lactulose. This is like a laxative syrup that helps bind the toxins. So essentially, you'll just be pooping out the toxins and it'll clear you that way. And the goal is to have at least 2 to 3 bowel movements a day. Sometimes if you have more severe cases, your goal might be a little bit higher than that. On top of lactulose, we might start you on medicine called rifaximin. This is an antibiotic that can help also with the confusion. If you feel or someone else tells you that you're just not behaving yourself, you're feeling confused, you're very sleepy, you should seek medical attention for this. And then if you're starting to have these symptoms, please do not drive. So what can you do about your cirrhosis? So first and foremost, no matter what cause of your cirrhosis, even if it's from virus or metabolic factors, you should stop all alcohol, that's beer, liquor, and wine, just because any further damage can lead to decompensations. Would also stop tobacco. Take all your medications as prescribed, and then make sure that you're getting your labs and liver imaging every 6 months as ordered. Make sure you stay up to date with your vaccinations. When you have cirrhosis, your immune system is a bit weaker than other people, so you want to make sure that you do protect yourself and have all your vaccines. You want to avoid medications like ibuprofen or Motrin Advil, naproxen, Aleve, Goody's powder, BC powder, especially if you have ascites, because these can definitely cause further injury to your kidneys. You can still take Tylenol or acetaminophen, but don't take any more than 2,000 milligrams or 2 grams a day. Avoid sleeping pills and then pain pills as well. And you should also avoid raw or undercooked shellfish, especially oysters, fish, and meat, just because this can cause severe infections in people who have cirrhosis. All right, I think that's all I have for you guys on cirrhosis.
Thank you, Dr. Heng. And just a reminder for everybody, please post your questions in the Q&A section. And Dr. Rabiee is gonna talk to us about, unfortunately, a very scary complication of cirrhosis, which is liver cancer. Thank you, Dr. Rabiee.
Thank you. Thank you for the invitation. Thank you to American Liver Foundation. I really love forums like this that we get to speak directly to patients and get their questions. So I'm going to briefly talk about liver cancer, which is, as Dr. Jacob mentioned, is a really unfortunate consequence of having liver disease. I want to start by saying that you might have heard from friends, family members, about cancer that is in the liver that has spread from other organs. So I want to differentiate that we have liver cancer that begins in the liver itself. That's the one that we're talking about today. It's also called hepatocellular carcinoma, or for short, we call it HCC. And then liver can also be a site where cancer from other organs in the body spread or metastasize to. And we're not talking about that kind of liver cancer today. So this type of cancer that happens in the liver, fortunately, only happens if there is underlying liver disease. And it also does not happen if you have very minimal or benign underlying liver disease. It usually happens when the patients have advanced liver disease or advanced scarring. How you heard from the last speaker how inflammation in the liver, whether it is caused by alcohol, viruses, fat accumulation, or any other type of disease in long term can cause scarring in the liver. And the end result of that is what we call advanced scarring, or the term that you might have heard, cirrhosis. So liver cancer, for the most part, happens in those patients who have cirrhosis. Now, there is a very specific type of patient with hepatitis B that might be at risk of liver cancer without having cirrhosis. So really, when we say that somebody might be at risk for liver cancer, we're talking about those two groups of patients. So those who have advanced scarring from any reason, whether it's virus, fat, alcohol, and those who have hepatitis B. Now, the tricky part about liver cancer is that it does not really have any symptoms. Usually when there are symptoms of cancer, liver cancer, we're talking about very advanced stages of liver cancer. Therefore, it is very important that we screen patients for it, since there are no symptoms. And screening, you might be familiar with screening for other conditions, right? Like mammogram for breast cancer, colonoscopy for colon cancer screening. Screening basically means that we're trying to look for a problem before it develops or before the symptoms develop. So the recommendation is that those who are at risk for liver cancer, again, those who have cirrhosis or certain folks with hepatitis B, need to be screened for liver cancer. And what we mean by screen is that every 6 months, there is need for a liver ultrasound, which is basically when the radiologist puts a probe on the right side of the body on the liver, looks for any lesions, as well as a blood test. So it is a commitment. It is every 6 months, give or take, and it should be combined with the imaging, which is the ultrasound usually, and the blood test, which should be ordered around the same time. Now, your doctor might recommend other modalities of imaging depending on the results that comes back. It might be a CAT scan, it might be an MRI, but for the most part, ultrasound, which there is no radiation, there's really no significant side effects with it, is the recommended modality that we would like patients to have every 6 months. Now, once liver cancer has been found, which usually the diagnosis is made by, as I said, a little bit more advanced imaging, like a CAT scan, like an MRI. The treatment options really depends on what stage the disease is. And what do I mean by stage? So how sick the liver is when this diagnosis is made, and how many tumors and how big those lesions are. Tumor, lesion, cancer, they're all kind of synonymous in this talk that I'm giving. For the most part, we do not recommend that patients get a biopsy, which means taking a tissue sample, putting a needle in the liver, and taking a sample to look at it under microscope. The CT, CAT scan, or MRI usually is sufficient. And the treatment options vary differently based on which stage the patient is at. So the sooner the cancer is found, the smaller the sizes, the less number of cancer lesions the patient has, and specifically if the cancer is limited just to the liver, there are really options to treat and cure that individual. So different options include removing the cancer with surgery, or even getting a whole new liver transplantation. Now, if there are multiple cancers, if the size is above a certain limit, there are other treatment options, most of which are offered by our colleagues called interventional radiologists. Those are treatments that are directed towards the tumor in the liver, and it will shrink the tumor or stop its growth. And then as cancer might get bigger or might spread outside of the liver, those are the situations that we usually discuss with oncologists or cancer doctors for systemic chemotherapy, which is the more traditional chemotherapy that unfortunately you might have heard in your family members or friends. Now, the old saying of one apple a day keeps the doctor away, we want to prevent it, right? So that's usually the best way to avoid getting it than actually treating it. Now, it's not as simple as that. I think some of this has been discussed in the previous talks, but in anyone with already underlying liver disease, we want to make sure that they avoid alcohol use. If there are viruses such as hepatitis B or C, they would need to be treated. Vaccination, we just talked about. It's very important, specifically getting vaccinated for hepatitis B. And then certain diets, there's really not a specific diet that I would bring up or recommend, but I would say that in those who have fat in the liver, have obesity, treatment with weight loss medication as well as diet can actually prevent progression of disease. So the less scar we have in the liver, the less likelihood of getting liver cancer. And then if and when cirrhosis develops or you do have hepatitis B, it is very important to stay on top of that screening with every 6 months, ultrasound and blood tests, because we know the sooner we diagnose liver cancer, there are better options that can actually cure you that we can offer. And that's all I wanted to say up front. I look forward to hearing your questions.
Thank you very much, Dr. Rabiee. And we already have some questions, and Dr. Baffy has been very proactive and started to answer them in the Q&A section. But Dr. Baffy, if you don't mind, just because this comes up a lot in clinic, just to say a few words about lean patients who still have
So yeah, that was one of the questions, and I was trying to answer that. It is indeed not a negligible population, and you have many people who have a body mass index as we use it routinely for the assessment of overweight or obesity in the normal or just barely in the overweight range. They have no diabetes, yet it turns out that they have fatty liver disease. When they have an ultrasound, indeed, they might even have elevated liver enzymes to some degree. So basically, and then there are all the metabolic dysfunctions that you might see. But those high blood pressure or there is a lipid abnormality. So all those things that will qualify you. And it's not because you have to have obesity or you have to have diabetes. The original definition, as I just showed, could be any of the metabolic dysfunctions. So it could be just something that you don't see unless you have a lipid profile, or unless it turns out that you check your blood pressure, and then, well, how many 30 years old check their blood pressure, for example. So, and then once you have it, and then you have fat in the liver on the ultrasound, you have the diagnosis. And then when we look at very complicated, we don't go into that right now, and then we don't use them routinely. But if you really have to prove that there is an underlying metabolic dysfunction, and then there is something that we sometimes call insulin resistance, or many of us don't really like that anymore. But basically, it turns out that those tests will tell you that something is really wrong with the way that the body handles carbohydrates, the body handles lipids, and then eventually the liver will be a suffering party to that problem.
Thank you. And we have more questions for you, but I'll jump quickly to our pharmacist, Dr. Rosenberg. So it's very exciting to see all these FDA-approved medications. How are we doing in the VA? We were able to treat so many patients with hepatitis C. Actually, the VA will be recognized as the most successful healthcare system in that regard. So how do you think we are doing with these new treatments?
Well, that's a very important question that you're asking. The VA is moving forward in ensuring that people who have recognized MASLD and advanced fibrosis are able to be evaluated for these emerging therapies. And as you know, what makes things very complicated is many of the patients who have MASLD right now don't even know that they have it. This is another reason why we're hosting this webinar, is we want our patients who are diabetic, who may have these other cardiometabolic risk factors that Dr. Baffy identified, to ask their doctor to check if they have an elevated FIB4 and to see if they need to manage their diabetes a little bit differently. As we heard, semaglutide may be used for diabetes as well as MASLD now. It's FDA approved. And so I think the VA will be moving forward more rapidly as the information becomes more available, not just to the patients, but also to the primary care providers. There are many other emerging therapies that are becoming available. So it's a very exciting field to be in today, and to see that we're finally able to manage many of the complications that patients might have, and maybe also start to prevent these emerging complications from occurring in the first place.
Thank you. And going back to Dr. Baffy, just because, of course, this is it's a topic that generates a lot of interest. There are a couple of questions about FibroScan. So I was wondering if you can comment on FibroScan and other modalities to look for scar tissue in the liver. And once our patients get a result, what to do with that, and what would be the questions they should ask their doctor?
Right. So, FibroScan is the second step that we use most of the time. There are other ways of telling about liver stiffness. What FibroScan fibrosis, because what FibroScan does, it measures liver stiffness. So it's very clear that all potential changes that increase the stiffness of the liver will be picked up by FibroScan. And that stiffness is not necessarily scarring. So that makes FibroScan somewhat vulnerable to conditions like when you have an increased blood flow into the liver, which is very easy to produce. You just have to eat a sandwich. And then obviously the liver will start working, and then there will be an increased blood flow because everything from your guts has to go through the liver to be detoxed, to be metabolized, to be, and so on. So obviously that's why we tell people that you have to fast a couple of hours, probably 3 hours before the test. Otherwise it will really cheat. if you drink alcohol before FibroScan, it will also do that. If you have some bile flow related disorders, it might also increase the stiffness. And all these things are not related to necessarily to fibrosis or scarring. So the good news is that FibroScan is typically credible if it's low. So if you have a normal value, then you cherish it because it's most likely true. If you have a high value, and then someone was just asking about that, I would say that one value is not enough to label you as having advanced fibrosis or having cirrhosis and so on. That's definitely not what we do. You really have to repeat that, and you have to kind of support what you see with FibroScan with some other imaging or laboratory modalities and so on. But a good FibroScan is most likely a true FibroScan. If there is a question, there are obviously others like MR-based elastography, which is definitely much more precise, but that precision comes with a much higher cost. So we don't really use it only in cases when we are in doubt about where we are with non-invasive FibroScan measurements.
Thank you. Moving along, so for patients who now have cirrhosis, question for Dr. Heng. What can they do in terms of vaccinations, timing of vaccinations, depending on the severity of their cirrhosis, anything special before or after liver transplant as far as vaccinations are concerned?
So really just the vaccinations to be cautious of, especially in light of transplant, are live vaccines. So things like MMR, but things like your annual flu shot, that's safe if you're not protected against hepatitis B, like Dr. Atoosa was talking about. We do recommend it. And some people who have had hepatitis B vaccines before, you might have your blood work checked and you're no longer protected. And so in those situations, sometimes we would recommend there's a newer hepatitis B vaccine that's 2 shots 1 month apart called Heplisav. That can be given if you if you are not on dialysis. Otherwise, you can go back to the 3 shots to try to boost your immunity for that one. COVID vaccines would be recommended and are safe. So really it's just those live vaccines like MMR that you should kind of be a little cautious about, and we wouldn't recommend with your immune suppression.
And one more question for Dr. Heng. Once somebody has the complications from cirrhosis that you mentioned, is there a way backwards for improvement, or all roads will lead to transplant once you get complications from cirrhosis?
So there is that, so you have the compensated and decompensated, but we also have what we call recompensated, just like people who have heart issues. So sometimes you can, if the medications can control all these symptoms, sometimes your liver can actually have all these symptoms controlled with medications. And even if you are not a transplant candidate per se, or your numbers that we look at or your MELD score might become lower where we don't have to consider transplant anymore. So really focusing on things to prevent progression of your disease, like stopping the alcohol, tobacco, making sure, you're on top of all your labs and screening so that we can catch things, and taking your medications as prescribed. That sometimes can help reverse some of these symptoms and have them better controlled.
Thank you. And I was ready to move on to Dr. Rabiee, but I have one more question for Dr. Heng. When there is a question in the chat about alpha-1 antitrypsin deficiency and progression of liver disease for patients who have MZ phenotype, which is the mixed phenotype.
Yeah, so the mixed phenotype, we have a couple patients with that. Typically, it's more of a second hit thing. So you're right, there is some increased risk of it, that typically if there is some sort of other risk factors, if they have a virus or if they have metabolic risk factors, that puts you a little bit higher risk for developing cirrhosis and liver disease from that. So that could be playing a part. Let's see, was there anything else in that question?
Oh, I think that's great. Thank you. So Dr. Rabiee, just tapping into your experience as a transplant hepatologist, can you comment on role of transplant as a treatment for liver cancer and availability for our veterans?
Yeah. So transplant is definitely an option which will cure not only the liver cancer, but also the underlying liver disease. We're basically replacing the liver with a new liver. I think the challenge with liver transplantation is that we are just replacing the liver. So all the other organs need to be assessed and everything else has to be working in tip-top shape for a patient to be eligible for liver transplantation and undergo surgery. Other than specific criteria, so there's a specific criteria for the number of tumors or cancers, as well as the size that needs to be met. Other things such as making sure that cardiovascular or heart disease is absent, making sure that the patient has support person and is able to commit to such a long road with transplant, all of that needs to be met. And then once all those are met, the patient will go on a liver transplant list with everybody else. And usually, because those patients usually have normal liver function, so there is a complication of liver disease to have liver cancer, but the liver function might be completely normal. So to give these patients priority on the list, there are extra points that are allocated to these patients, and it usually takes about 6 months for them to get these. So even if somebody is referred to liver transplant evaluation and the process starts today, it would at least take, I would say, probably closer to a year for a patient to actually undergo liver transplant. The other thing that I would say is that another option to think about transplant is if that individual has a living donor, as in another person who would be able to give part of their liver to the individual who has liver cancer. So that would eliminate everything that I just said as far as waiting 6 months, waiting for the extra points. Regardless, I would say for those who are able to get surgery, as in just take that part of the cancer out of the liver without actual transplantation, that's usually our priority, our number one treatment, because again, liver transplant, especially coming from deceased donor, there are many people on the list. The chance of getting transplanted is not super high, and then it will take a very long time. And then we should also really note that although we are removing one problem, patients who get a liver transplant, they have pretty good outcomes. They can live for a very, very long time, but they are going to be on medication that would suppress their immune system for the rest of their life. So really, we try to look at it from different ways, and that's why every time we discuss with the patient liver cancer, there are multiple people that are involved because liver transplant is really just one option.
Thank you. Question for Dr. Teddy, actually might be multiple part question. Why is it important for a veteran to advocate for their cancer diagnosis to be discussed in what we call liver tumor board, even if they live in remote locations, not close to a university center? And are there any other options when the medications or interventions won't help much with the cancer?
Thank you for the question. So as was stated by Dr. Rabiee, liver tumor board is really where the action happens in terms of developing a comprehensive care plan for a person with liver cancer. And because the VA is a national health system, which has both remote and urban and rural stations, oftentimes allocation of resources are more concentrated in the urban centers than in the rural centers. And for that reason, there are many regional tumor boards across the country where stations will actually ask the academic affiliated urban centers to talk about the cases. So for example, in New England, we have such a setup so that we can provide comprehensive liver cancer care across the region. So that makes possible the receipt of care for veterans. They can either travel to the station that can offer them care. Sometimes we can decide collectively that that care should be rendered in the community. But the bottom line is you come away with a comprehensive care plan. What happens too often in liver cancer and in all cancers is that you go from specialist to specialist to specialist. You hear a lot of different opinions and you still can't kind of piece together what's the next best step, right? So the tumor board actually consolidates that conversation and allows the patient to actually hear the plan once it's really vetted by all those specialists, as opposed to having to go to each particular specialist. These regional tumor boards exist. It's very reasonable for veterans to ask, hey, can my case be presented at a tumor board? And that you should be asking that. And so hopefully that'll help to be sure that you have an appropriate care plan. There are many, many treatments now for liver cancer. What used to be considered a very highly lethal cancer, liver cancer, people are now surviving for years. There are curative therapies, there are palliative therapies, and there are best supportive care, which is essentially making sure that symptoms are managed. It really depends on the stage of the disease, as well as other medical problems that a patient may have. And so we have to take all of that into account to really decide what the proper plan is. But once you have a life-limiting illness like cirrhosis that's then complicated by another life-limiting illness like cancer, it's very reasonable then to consider principles of palliative care. How do you emotionally handle the diagnosis? How do you bring your loved ones into the conversation? How do you manage symptoms that come up along the way? And how do you manage just the day-to-day logistics that you have to consider when you're dealing with a heavy diagnosis, right? So there's a lot that, we as doctors, we're sort of trained to take care of your condition. And of course, we want to work with you and we want to know what your goals of care are, but this is really a comprehensive approach to, who you are, what's important to you, how to optimize your quality of life, and how to really make sure that we're dealing with anything that's either mental or physical that could get in the way of you enjoying your life.
Thank you so much. Question for Dr. Rosenberg, because I'm well aware and I use it all the time, all her work with the dashboard. So if you can just comment for our audience, what goes on behind closed doors, how we try to keep track of doing the right thing for our patients.
Yes, thank you for that question. So behind the doors, since the VA is one of the largest healthcare systems in the United States, we are very fortunate that we have a database that we call the CDW, and it contains all of our veterans' laboratory results. Specific to hepatitis B and C, just to give an example, if you are tested in the VA for either of these viruses, that information resides in the database, and we are then able to pull that information into a very specific report. That becomes important because in the olden days, before we had good therapies for these viruses, we didn't really know what to do with them. We monitored our patients, we looked for cirrhosis or progression, and we treated them when they had complications. Now that we have curative regimens for hepatitis C that are easy, we can find that individual on our report. We can alert their primary care provider that we know of this individual and to discuss with them the possibility of either being referred to our liver clinic for an evaluation and for therapy, or if they're in another clinic, such as an infectious disease clinic or a substance use clinic or any other place where there may be an expert who can address it, they can then have a discussion with that individual on how to best proceed. And we have this for hepatitis B and C. We're developing this for MASLD. We have it for cirrhosis. So we can really develop a comprehensive database of patients where instead of waiting for the veteran to come in and identify a problem, if we see a problem that we feel needs to be addressed sooner, we might reach out to you directly, but typically we'll reach out to your primary care provider and ask if this is something that you as a veteran might be interested in embarking on. So I hope that answers the question, and thank you.
Thank you very much, and thank you and to our panelists for their hard work to serve our veterans. And before we get kicked out of the Zoom link, I'll give it back to Morgan.
I cannot thank all of you enough for today. I really appreciate your time and your effort to be here with us and the invaluable education that you have provided, not just to the attendees, but to all of the staff at ALF over the last year as well. So for all of our attendees, if you are looking for more information after today's webinar, we do encourage you to visit liverfoundation.org. There you will find more details about our virtual as well as our online support groups, opportunities to get involved as an advocate, our Veteran Information Center, as well as access to our Liver Health for Veterans Facebook group. Finally, we invite you to connect with us on social media. You can find us on Facebook, Instagram, LinkedIn, X, which is formerly known as Twitter, as well as our YouTube page, where this video will be housed for future viewing. We look forward to staying in touch with you all. Thank you so much for today.